Okay. So we will stop, get that talk through, and then we
Hello,
continue the conversation. Hello.
my friends and colleagues. It's a pity don't be able to join you in Jeddah this time, but it's possible to do by remote. And I'd like to share with you some thoughts about the Zone 2 coverage with a landing zone by thoracic. That is my disclosure, please, for this particular talk. And we follow that index. If we remember the Chamorro classification of the different, zones of the aorta, zone 2 is the just the zone of the arch in front of the left subclavian artery, between the left carotid artery and just after the left subclavian artery. So more or less depends on the series you are consulting. TIVR needs the left ventricular coverage in about 20 to 50% of the cases. The pathology we face with this particular technique of the thoracic endografting with a landing zone at the level of the zone 2 is mostly related to the type B dissection, also some trauma, as well as some aneurysm. About the consequences of the potential, coverage of the left cavern artery, there are three most important. The stroke is one of them. The spinal cord ischemia is the second one, and the left arm ischemia is also quite obvious if you cover your left cavern artery. All of them are quite important, for instance. You can imagine there are specific circumstances, like, for instance, a mammary coronary bypass. Then, if you cover this artery, you can get some troubles in terms of cardiac ischemia. From the literature, we know that looking for this particular meta-analysis, that the revascularization, the need for revascularization is totally justified because you avoid, in favor of the revascularization, you reduce the stroke risk, you reduce the spinal cord ischemia as well as the left heart ischemia. There are more different kind of predictor for complications, but all of them, the stroke, paraplegia, and the spinal cord ischemia, are related, or one of the most important or relevant factors are the left subclavian artery coverage without revascularization. So that is the reason why the most international guidelines recommends to revascularize the left subclavian artery if you plan to cover in elective cases and some kind of an emergency cases, like, for instance, if the patient is doing with a mammary coronary bypass, for instance. That is, collected in the European guidelines as well as in American guidelines. Some kind of different kind of options you have. You have uh, all the shelf options as well as the custom-made options in order to maintain the left subclavian artery, revascularization, or maintain the patency of the left subclavian artery. The most common classical one is the left subclavian artery bypass from the carotid artery, but there are some series with demonstrate some kind of complications. About the 29% of the cases with early complications, most related with the phrenic nerve palsy, and also recurrent laryngeal nerve or axillary nerve, or evacuation of nerve hematoma, or even the lymphorea or lymphoragia. The primary patency rate for this kind of bypasses are so high at the 3 and 5 years. Other series for the same kind of technique and from other groups are less, morbid, with less strokes, with less axillary nerve, less phrenic nerve injuries that represent that probably the technique itself, it depends of the surgeons, could be more or less morbid, with the primary patency still so high, 92% of 5 years. It's important to recognize that if you change the left common artery by the axillary artery, then you can reduce the phrenic affection as well as the lymphatic leakage. That could be beneficial in terms of comorbidities reduction. The average cost for this kind of thoracic endografting plus the left subclavian artery reconstruction by surgery, bypass, or even rerouting or reimplantation is about 9,000 euros. There are some specific circumstances, anatomical ones, where you have the left vertebral artery just taken off directly from the arch, and then could be recommended to perform a solitary bypass from the carotid artery to vertebral artery. That would be very nice. In situ fenestration, as you can see here, is possible from inside. Is a retrograde in situ fenestration for the left vertebral artery that is taking off the indirectly or independently in the arch. But moving forward with the in situ fenestration, that you have also nice results with the technical success 100% in this urgent emergent series, mostly 92% of the cases. And then with a nice patency rate, with a very low strokes and spinal cord, prevalence and mortality, yes, because it's an urgent emergent repairs. And the patency at 10 years is about 91%, so high patency rate. And the average cost is about 12,000 euros. The same for the in situ needle fenestration. The experience in the western part is not so high, but it's an experience from Italy with 50 patients with nice, mostly elective cases with very nice results, even with primary patency 100% for more, with no endoleaks and no any kind of drawbacks with the fenestration itself. So one of the most important, tricks in order to be successful in the in situ fenestration, needle fenestration, is to have a angle between the subclavian artery and the aorta is bigger than 40 degrees. The threshold is about, the threshold is in 40 degrees. More than that is very convenient or very, optimal. Below that, more angulated, more acute angles could be less, prone to success. About the physician modified stent graft, is also possible because there are so many anecdotal and non-anecdotal, series published already, with an average cost about 10,000 euros, including the endograft. With in this particular series, with an important number of emergencies, technical success so high, and also the mortality is 10%. Remember that is an important number of emergencies here, with a very small stroke rate, about 3%. And the stent was needed for left coronary artery in 70% of the cases. Scallop endograph or combination scallop plus fenestration